It is important to ask the job and the patient's lifestyle, wherein jobs requiring repetitive, vigorous upper extremity activities such as lifting, throwing, and carrying, or those that require single forceful extension of the upper extremity such as pushing and wrestling, are more commonly cited mechanisms of injury seen in kickboxers, weightlifters, baseball players, and skydivers. Usual chief complaints of these patients are elbow flexion weakness, shoulder flexion weakness, and forearm supination. They also complain of localized impaired sensation over their lateral forearm, over the territory of the right lateral antebrachial cutaneous nerve, or a branch of the musculocutaneous nerve. So also the patient will also complain on burning, tingling pain on the lateral forearm. Observation palpation, the patient may also present other expected signs such as poor muscle tone, reflexivity of the anterior arm, marked muscle wasting, and also possibly fasciculations. Upon palpation, the patient may also have weak contractions, which will be noticed by the PT, over the biceps brachii and the brachialis muscle during the manual muscle testing.
Okay, kanang nga ba na sakit?
No.
Okay, yan na.
Neurological assessment, we need to assess on the sensory and the deep tendon reflexes, where in the sensory assessment, we need to assess the C5 to C6 dermatomes. If there is a problem on the distribution, perhaps the patient may have cervicular radiculopathy or some problems with the brachial plexus. But if ever the patient will present problems on light touch, pinprick, temperature sensation problems on the lateral forearm only, hence the problem is only on the musculocutaneous nerve.
Sige sir, kanina po, nakiyangan yung sakit. Karon kay, matag sa mata, open sa sir. Sige sir, yun sir. Okay sir, so open yung eyes sir, so na nakingatan ni, kuhaan kay, katulad mo na makita. Close eyes sir, open ang pinasa sir. Ano sir? Close eyes sir. Okay, so patang sir, ano natin, duha ka sir, mo siya init, mo siya ang bugnaw. Karon kay, ina ko sir, nabati sir. Yung mata sir? Okay, so na nakita, nabugnaw kanin. Dapat sir, na ayun siyang shape, so nakita ka, karon kay, kailangan mo feel. Taas sir. Kanina ko. Okay sir, pinasa mata sir. And also for the deep tendon reflexes, you need to assess on the bilateral upper extremity biceps brachii tendon, wherein the affected leaf of the patient may have a DTR grade of 210, or the patient may be reflexive, hyperreflexive, or have normal reflexes. Ha, ako ni siyang itap sir niya. So wala lang gyud kay baton ha. 2, 3.
You need to assess on the arm and period of the patient. Usually the period of the patient is within normal limits or functional limits, whereas the arm would present a loss of motion of shoulder and elbow joint flexion primarily in forearm supination. The patient can also achieve full range of motion but complains pain by the end of the range of motion.
Okay sir, okay sir, taas may sir. Okay sir. Sir na, wala na dito mo pa 1, 2, 3, go. Sir. Okay, so measurement ani tinasa ani.
Also, during the manual muscle testing, the patient may experience a decrease of elbow flexor muscle strength with a grade of 3 or 2. If the problem is because of the weakness of the biceps brachii, hence during the elbow flexion forearm supination test, there would be a problem or a observed decreased muscle strength. But if the brachialis is the problem, there would be a decreased muscle strength during the elbow flexion forearm pronation test of the MMT. For the muscle bulk test, for a prolonged musculoskeletal nerve injury, there would be a biceps brachii muscle atrophy. Hence, a marked significant difference during of the two extremities. Perhaps across range of motion is just observed also together with other assessment, wherein the patient would have a difficulty in flexing the shoulder and elbow during observation, during musculoskeletal and coordination assessment. And for the coordination assessment, the results will show impairments due to the patient's decreased functional ability to flex the elbows and also shoulders during the finger to nose and multidirectional functional reach test. Also for the functional assessment, the patient will state that he has the inability to perform self-care, upper extremity dressing, transfers, eating independently secondary to the decreased muscular strength and loss of motions of the elbow flexor, shoulder flexors, and it would be modified independence, or the patient would need minimal to moderate assistance.
Okay, di mo ka mag-release sa gilid sir. O di sa tawag sir, sa mga gamitin mo kanina mo. Kung mag-kuan sir, kanang mag-pagchat ko ka mag-kuan ka, o di sa sir. So kung isa din na kasi mag-inis. So sige sir.
For this special test, we have the musculocutaneous nerve tension test or the upper limb tension test, wherein the patient will be positioning in a supine position to
karon kay straight ni mo kang kuan sir. Naha, straight ni mo bayo kay dibawg sir ha. Sige, ay bawg. Kung manana kanimo hang kamot, imong thumb sud sa imong fist sir, pag mag-fist sir, so di mong thumb. Paggahi sir, kung unsay kayo nimo, sunod na kay imo kuan kanimo wrist paubos. Ana sir ha. Okay ha. 1, 2, 3, go.
So the patient would report of symptoms of reproduction wherein there would be anterolateral forearm tingling or lateral forearm tingling, burning pain, and numb sensation. Also, another test is the tendon signs or tapping over or distal to the nerve distribution. So the patient will also report tingling on the anterolateral or the lateral forearm that would indicate a positive tendon sign. For the PT plan of care, we have electrical muscle stimulation or EMS for elbow flexors. Pulse duration is 1 ms. Pulse interval is 3 ms using bipolar technique for 5 to 10 minutes with rest every 30 contractions thrice a day while in a sitting position with forearm resting on the table to stimulate twitch contraction for the nervated muscles. Also, we have sensory reeducation along the C5, C6 dermatome or lateral antebrachial cutaneous nerve distribution or the lateral forearm, while sitting across the therapist with forearm rested on the table for 5 minutes to improve sensation for better performance of exercises, receiving tactile cues and increase functional independence. We have the reflex hammer, sharp and dull tips for pain, hot test tubes and tines for tuning for cold for temperature, cotton ball for light touch, and 2 pins for 2-point and bilateral tactile discrimination finger for pressure. Also, we have conscillocutaneous nerve flossing or glide in standing position or pwede in sitting position, facing the mirror for 3 to 5 minutes to stretch and improve ROM and reduce pain. So elbow in extension, wrist in a neutral position, a hand forming into a fist with thumb inside. So pre-glide activity is to have to alternately ulnarly and radially glide the wrist. And the actual flossing will execute a shoulder extension and symptoms are reproduced, but it encourages the nerves to glide normally along the extremity. So for the ROMs, we have the assisted active ROMs. For shoulder flexion, supine or prone elbow flexion, forearm supination times 2 to 3 sets times 8 to 10 reps for 5 minutes in sitting position and standing position to increase ROM in preparation for strengthening exercises and functional activities. We have the PREs or the progressive resistance exercises using PNF techniques with or without yellow or green therabands times 2 sets times 5 to 10 reps following the Oxford principles by counting aloud. So 3 counts for concentric contraction, 5 counts for isometric contraction, and 3 counts for eccentric contraction for 10 minutes to increase muscular strength with the basis brachii, brachialis, and coracobrachialis in preparation for functional activities. We have the unilateral UED1 flexion to practice bilateral symmetrical D1 flexion. This is just for the patient not to exercise only one arm but equally on the other side. Also, we have the bilateral symmetrical D2 flexion and bilateral asymmetrical D2 lifts. We also have the strengthening exercises for forearm supinators using a yellow-green TheraBand times 2 sets times 5 reps following a certain principle by counting aloud. Also, 3 counts for concentric contraction, 5 counts for symmetric contraction, 3 counts for eccentric contraction for 3 minutes to increase muscular strength and basis brachii in preparation for the functional activities. We also have coordination exercises covering non-equilibrium and multi-directional functional reach for 10 minutes to increase UA coordination in preparation for functional activities. We have a holding a medium-sized ball with both hands and rotating the ball alternately to supinate and pronate affected upper extremity. So sound upper extremity rotates the ball to guide the movement of the affected upper extremity times 3 sets times 5 reps. So we have a picking up the tennis balls from the table and tossing the ball to the therapist standing behind, executing a D1 flexion PNF pattern or an overhead toss or ipsilateral toss to produce shoulder and elbow flexions times 2 sets times 5 reps. We also have functional training for 15 minutes in front of a mirror to increase functional independence in activities of daily living such as self-care, upper extremity dressing, transfers, and eating. We have a stationary running with arm swinging, producing shoulder flexion and elbow flexion. We also have simulating combing hair, holding utensils close to the mouth, simulating eating, and we have for ADL activities. We also have activities for baseball players such as partial baseball batting that doesn't require swinging beyond sagittal plane. We also have partial baseball throws but no follow through, and etc. All activities are done gradually by letting the patient count. We also have for the weightlifters, we are having simulating weightlifting training bar without plates, gradually reaching full range of motion with minimal assistance from the therapist. Also, we have dumbbell lifting with an arm supported on a table or cushion foam with either with forearms supinated or pronated. We also provide patient education wherein we educate the patient on the mechanism, presentation, and occurrence of pain with the condition. We also tell them what is the background and the risk factors of the injury and other precautions of the injury such as relative rest or reduced participation in vigorous activities. We need to avoid lifting heavy objects using affected upper extremity and to avoid Valsalva maneuver, so we need to count.
So next would be radial nerve injury at the level of the spiral groove. So there are actually different levels of radial nerve injury depending on the areas to which the nerve is being compressed. So a little bit of anatomy for radial nerve. So radial nerve is the largest terminal branch of the brachial plexus with contribution from C5 to C8 nerve roots. It continues from the posterior division of the plexus and runs along the lateral wall of the axilla, supplies the triceps muscles, and then winds around the spiral groove of the humerus. It then pierces the intermuscular septum below the deltoid and supplies the brachioradialis muscle and extensor carpi, radialis longus and brevis above the elbow. It then enters the forearm between the biceps and brachioradialis muscles and divides into the posterior interosseous nerve and superficial radial nerve at the level of the elbow joints. So in the picture presented is the radial groove, as you can see on the proximal part. So for differential diagnosis, so it should be distinguished properly with regards to the more proximal radial injury as it presents with different signs and symptoms. For example, for more proximal radial nerve injury, it has it has diminished triceps reflex. However, for radial nerve injury at the level of spiral groove, there is intact triceps reflex. However, there is diminished or absent brachioradialis reflex. So it should be taken into consideration as well. Then we have examination results. So there's to be subjective for occupation chief complaint, mechanism of injury and lifestyle, general appearance, neurological assessment, sensory assessment, deep tendon reflex assessment, and musculoskeletal assessment as to ROM and monomuscle testing. Then fine motor skills, of course. Then coordination assessment. The only impairment would be equilibrium for upper extremity. Then functional assessment, specifically affected would be those activities that requires the upper extremities. Then special tests using ULNT3 or upper limb neurodynamic test 3, in which the nerve bias would be the radial nerve here, and positive would be indicated by reproduction of signs and symptoms. Then problem list. Then aside from physical therapy management, so there could be splinting and dynamic orthosis that can be used for the patient. Then next would be the videos for objective and plan of care.
Good afternoon, my name is Maria. I'm so happy for today, ma'am. So my name, your age, your birthday. Okay, so I'm going to ask you a few questions. Okay, okay, and I should have to speak here. Okay, so first off, ma'am, so I know what's your work. Okay, okay, and I want to know why you're here today at physical therapy. Okay, so maybe something about that. And I know any disadvantage that you think might have put into your current complaint. Okay, so what do you expect to do recently? Okay, and when did that happen? Okay, and I want to know about your daily routine. What do you usually do to your home, ma'am? Okay, okay, ma'am, that's very informative. Thank you. And also, ma'am, may I know if you're active? Okay, that's great. So patient walk to physical therapy clinic, patient has a bit of stroke. So we have motivation and therapy. Okay, so ma'am, after going through the very important examination, okay, can I start now? Okay, so first off, ma'am, I have here a sharp tip and dull tip. So tell me, say sharp if it's painful and say dull if it's not. Okay, so close your eyes, ma'am. Okay. Sharp, sharp, dull, 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 sharp, dull, sharp, dull, sharp, dull, sharp, dull, sharp, dull, sharp, dull. Next, I have here like brush. Say yes if you feel it, and no if not. Close your eyes again. Okay. No, 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 no. Yes, yes, no, yes, no, yes, no, yes. Okay, let's give it out. And next, I have here have a cold test tube. Say hot if you feel hot, and say cold if you feel cold. Okay, ma'am. Okay, close your eyes. Cold, hot, cold, hot, cold, hot, cold, hot, cold, hot. Okay, so next, I'm going to put pressure on your skin with use my fingers. Say yes if you feel it, no if not. So close your eyes again, ma'am. No, yes, no, yes, no, yes, no, yes, no, yes, no, yes. Okay, so for the assessment, both the back upper extremities are to be tested. So now I want you to give me your hand and then you look away and close your eyes. Okay. So the three guys to be tested for both upper extremities. Okay, I'm going to give me your hand, put it on the table. Okay, so just relax. Okay, so our movement for today, I want you to raise your finger up on your finger first. Then that would be our movement. So when I say on count of 3, you need to raise the finger that I tell you. Okay, to the roof. Okay. So that's our first index finger. Okay, ma'am. So on count of 3, I want you to raise it towards the ceiling. Okay, 1, 2, 3, go. Okay, is that you can do? Okay, okay, that's good. So finger extension needs to be tested in both upper extremities in all 5 fingers. Mom, I want you to lie on the bed. Okay, carefully and slowly. I'll just place a roll towel under your arm. Okay, so for our movement. Okay, so can you place your palm towards the ceiling? And on my count, I want you to raise your forearm towards the ceiling. Okay, 1, 2, 3, raise. Okay, so that would be our movement. Okay, so just relax. Just relax. Okay, and wait for my cue. Okay, okay, ma'am, just relax. Okay, 1, 2, 3, raise. Raise as much as you can, ma'am. Is that you can do? Okay, 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 that's good. So pressure range motion for elbow flexion needs to be tested for both upper extremities. So I'm going to give you your hand. Make sure that your palm is facing towards the floor. Okay, thank you, ma'am. Okay, so when I count 1, 2, 3, I want you to raise your fingers towards the ceiling. 1, 2, 3, go. Okay, that's good. So I want you to do it again. Okay, and I want you to try to resist my hand. Okay, I'm just going to give something first. Okay, 1, 2, 3, raise. All you can do is at all. Okay, I'm going to give more resistance as you can. You can barely resist my hand. Okay, thank you. So fingers of both upper extremities need to be tested. You sit on the bed and can you give me your forearm? Okay, so the therapist needs to support the patient's shoulder and resistance here. So I want you to bend your elbow towards the ceiling. 1, 2, 3, go. Okay, that's good, ma'am. Okay, so I want you to do it again like you and try to resist my hand. Okay, 1, 2, 3, raise, bend, bend. Is all you can do? Okay, so I'm going to give more resistance, ma'am. So elbow flexors of both upper extremities need to be tested. Okay, so ma'am, I'm going to use some very fun exercises. I want you to listen to my instructions. Okay, so first I want you to reach this highlighter from my hand. Okay, and now I want you to hold it, grasp it, and release it on the table. That's good. Then next I want you to hold this ball. Okay, hold it. Okay, that's good. And next I'm going to give you this bag as if I'm asking you to go out. Just hold it to it. Okay. Then next I want you to hold and keep this cone here. Just hold it as if you're about to go to the bathroom and do self-care hygiene something. Then next I have things here on the table, and I want you to pick up this small earring. Okay, hold it to it and transfer it over to the next side. Then pick up the beads and transfer it to where you transferred the earring. Okay, that's good. And I'm going to give you a paper and can you hold it on the side. Okay. And now I'm going to give you a key and can you show me how you're going to unlock your door? Okay, that's good. Okay, so thank you, ma'am. Okay, ma'am, so I want you to do something and so much. Okay, so I want you to point or touch your index finger, right finger. Okay, that's good. Follow it, follow where it goes. Then next I want you to place your nose like this. Okay, like this. Okay, okay. And I want you to touch my index finger. Then your nose. Do it again. Just make sure that you are touching both your nose and my index finger. And now I want you to tap your hand on your lap. Okay, so coordination assessment. So both upper extremities need to be tested. Only one upper extremity. Same with fine motor skills. Okay, so next I want you to perform some very finger activities. Okay, so first I want you to demonstrate to me what you do at night before sleep, like skincare maybe. Okay, so okay, brushing your teeth. And now you're going to put on your night cream. Okay, ma'am, just try to imagine you're going to go to sleep. And next as you go to bed, I want you to try to put on a shirt, try to button them as if you're very ready to sleep, or maybe not, if that's what you want. Try to button them carefully. Don't try to think this is or something, just try to demonstrate to me and try to unbutton them and remove them as if you are not going out. Okay, so thank you, ma'am. Okay, so next I want you to transfer from your bed into your bedside chair. Okay, just careful. Okay, so from your bed and go into your chair carefully. Then back to your bed again. Okay, thank you, ma'am. So for a special test, upper dynamic test for your T3. So now I want you to lie on the bed. Make sure that you're on the very side. Okay, so good side is tested first before the bad side. Okay, I want you to make sure that your left side is not touching the belly side of the bed. Okay, so the therapist needs to press here, shoulder flexion, then elbow flexion first, and then make sure that the fingers and thumb are flexion as well. There would be flexion for arch to be pronate, and then put stress on the radial nerve if the elbow is extended. Okay, and to confirm it, so now I want you to try to bend your head towards the right. So make sure that there will be collateral flexion for confirmation. Okay, so thank you, ma'am. I want you to place your hand on the table so it's only for the affected hand. I'm going to put a hand box and assuming that the patient's the side having gotten is with no limit zone. So can you start on my face? So it's heat. It means it's hot and can you it? Place it next to me. Okay. So again, this is what I was talking about. So if you feel like you can't tolerate it anymore, so tell me immediately so I can do something or maybe stop it. Okay. So this will be done for me after putting the box. This would be let it sit in for 15 minutes. Okay, so when the therapy is done or the paraffin box 15 minutes is done. So 15 times for participation operation. I want you to put your hand on the table so this is done for the affected extremity. I want you your hand to be registrated on the sensations that have been lost. Okay, so this is sharp, so this is for pain. I know you feel it, but this will just registrate your skin or your affected part, and this would be for light touch. So this is a brush. Okay. And next, this would be for dull tip. Yes, ma'am. Okay, and this would be for the hot test tube. This is heat. hope your skin knows it. And this will be for the cold test tube. So this is cold. Yup, okay, that's great, ma'am. Exercise, I just want you to close open your hand. Your affected hand, so on my cue, I want you to do it. 1, 2, 3, go, ma'am. Okay, so that's it. And that will be done for 3 sets, 10 repetitions each set, ma'am. Good, ma'am. The next exercise, I just want you to bend your elbow towards the ceiling. Okay, on my cue, 1, 2, 3, bend. Yes, and then down, and bend, and try to repeat the motion for 3 sets, 10 repetitions each set. That's good, ma'am. Next exercise, this would involve the core muscles, the core muscles. So you lift up your hand, ma'am, and can you raise your fingers towards the ceiling? Okay, that's it. So now go to resistance, and make sure that you try to move your fingers against resistance, okay? This will be done for 3 sets, 10 repetitions each, ma'am. Okay. We're going to use the core band, ma'am, resistance, and the same way what we've done before, raise your, bend your elbow, 1, 2, 3. Okay, that's good. And now I'm going to apply resistance, make sure that you bend your elbow against resistance. And again, and this will be for 3 sets, 10 repetitions each set, ma'am. Thank you, ma'am. I want you to cut the paper that I have given you together with the scissors that I have given you, okay? Can you start? Okay, just cut it in a shape that you want, and let's do this for 3 minutes. This would be actually helpful, ma'am. Okay. So I want you to grind coffee beans in the coffee grinder as we are about to make yourself a cup of coffee. Okay, that's good, ma'am. Okay, so next I want you to wear a shirt, button it, and then button it, then remove it, okay? Okay. Okay, button it. Make sure that you would complete buttoning it. Okay, that's good, ma'am. And now try to unbutton them, then remove it. Okay, that's very good. Okay, now can you tie the shoelaces off the shoes in front of you? Doing great, ma'am. Keep it up. Yeah, that's good. And demonstrate me as to how you would eat at home. Okay. Okay, that's good, ma'am. Okay. Okay, so now can you toss the ball to me? Okay, yeah, so we're going to do this for 3 sets, 10 repetitions each set. Okay, you do it again. That's good, ma'am. We're going to do this for 3 sets, 10 repetitions each set. That's good. Okay, so now can you dribble the ball? That's good, ma'am. We're going to do this for 3 sets, 10 repetitions each set. Okay, so now can you bounce the ball on the wall? So assuming this is a ball. So we're going to do this for 3 sets, 10 repetitions. That's good, ma'am. Okay, that's all we're going to do today. I just want you to demonstrate to me on how you do your self-care, self-hygiene, and your same way to use off your hands, okay? Okay, so I'm going to start talking, ma'am. Okay, so now just be careful. Just don't brush yourself. I just want you to demonstrate and take this test, and also this will be very helpful for you. Okay? Okay, so now you're brushing your teeth now. Now you're putting on your face cream. Okay, ma'am. So now you're out on the toilet, and you're going to button your shirt. Okay, so I want you to do it carefully and slowly. It takes some practice for you to be able to regain the skill of perfectly buttoning and unbuttoning shirts. Okay, so thank you, ma'am.
So up next is the radial nerve injury, specifically the pin compression syndrome or the posterior interosseous nerve syndrome. So the PIN compression syndrome, this is a compressive neuropathy of the PIN, so the posterior interosseous nerve, which affects the nerve supply of the forearm extensor compartment. So PIN is a branch of the radial nerve that provides motor innervation to the extensor compartment. So as you can see, in the screen, we have the radial nerve. And then the PIN passes between 2 heads of the origin of the supinator muscle and the indirect contact with the radial neck osteology. And then this nerve passes over the abductor pollicis longus muscle origin to reach the interosseous membrane, then transverses along the posterior interosseous membrane. In this slide, these are the innervations of the PIN. So ECRB, but most often the ECRB is innervated by the radial nerve proper, but it has small innervations from the pin. So we have the EDC, the EDM, ECU, supinator, APL, EPB, EPL, EIB. So basically, they are extensors of the wrist, extensors of the hand, and extensors of the finger. And take note that there is no continuous innervation for posterior interosseous nerve compression syndrome. History taking, most probably the patient's chief complaint is vague proximal posterior forearm pain. And then for etiology or some of the mode of injury, PIN compression can happen in elbow fractures, laceration, or compression from the soft tissue masses such as lipomas, neurofibromas, schwannomas, and hematomas. And then it may also happen because of the elbow synovitis from rheumatoid arthritis. Then another mode of injury is blow to the proximal dorsal region of the forearm, and mostly repetitive activities that involve gripping, wrist supination, and pronation with a component of wrist extension. So for occupations that may have this, that is probable for this disorder are carpenters and or manual laborers because of how they work. And then any occupation that has strenuous use of the forearm. So some other diagnostic techniques are imaging, which specifically nerve conduction studies. So if there is nerve conduction studies to the extensor ilicis muscles, they are, and when the results are abnormal, meaning they have the pin compression syndrome. So some conditions that we can DDX from pin compression syndrome, one is radial tunnel syndrome. So they may involve the same site of compression as the pin syndrome. However, radial tunnel syndrome presents with forearm pain without motor weakness. Pin has motor weakness but no sensory. So another is Wartenberg syndrome, also known as scleralgia paresthetica. So compression of the superficial sensory radial nerve. And then because the superficial sensory radial nerve has no motor innervation, the symptoms are purely sensory. So hello sir, ako si JGR po, I will be your for today's ha. So karon sir, I will be doing the objective examination to see asa nga part sa imong body nga naay mga differential sir, okay? So pwede akong mag-start sir. So first, I will assess the patient's pain. So tell me sir, if makafeel ka sakit siya, wala na sir. Okay, dito sir. Okay. Dito sakit sir. Okay, so pain on the posterior from this sakit. Okay, now checking for edema and swelling. So in the posterior forearm, there is swelling and there is edema. So karon sir, proceed ko with the sensation na testing sir. So this is the reflex hammer, so this is the sharp tip o ang soft tip. So kani sir, man yung ma-feel dapat siya? Pin prick, light touch. Okay sir, kani sani?
Pin prick,
Kani?
light touch.
Okay sir, so I will assess the patient sensation. Kaya rin sir dito.
Pin prick, light touch. Pin prick, light touch. Pin prick, light touch. Pin prick, light touch. Pin prick, light touch.
Okay, so patient sensation is normal as to the distal forearm and hand. So now sir, we'll be assessing your range of motion. It's for me to see kung saan ka nakuha ang movement sa kung ang joint in your body sir. So now we start with your supination sir. Itry to kanina position sir. So I want from this position sir, I want you to do it like perform like that. Okay, ready sir. Ready, 1, sir. On my cue, ano yung button sir. 1, 2, 3, go. Sir. One yung sir. Okay, so patient has limited supination. Next is finger extension. Okay, sir. Okay sir, so lift yung fingers already. 1, 2, 3, sir. One yung sir. Okay, so next is wrist extension. So for sir, itry ka sir. Okay, ready. 1, 2, 1, 2, 3, go. Okay, one yung sir. Okay, wrist extension. And then last is ulnar deviation. Ayun, isa ka. So from this one, sir, move ka. From this range, right? Ready? 1, 2, 3, go. Please move. One, sir. Please move the range of motion. Okay, so after, you proceed to the muscle testing. So this is for you to check if what's strong muscles na. You just start with stimulation. So from this position, I want you to try to add yung arm above the distance. Ready? 1, 2, 3, go. Okay, sir. One more, sir. Okay, so now, next is finger extensors. So, try to lift your fingers after yung distance. Ready? 1, 2, 3, go. Okay, one, sir. Okay, next, muscle strength of the ECU. So, sir, what I want you to do is, I want you to isa kayo mga Okay, sir. Ready? Ako doon, please. Ready? 1, 2, 3, go. Okay, sir. Okay, thank you. Lastly, sir, let's check your muscle book test. So, this is for us to know if unsa ka ako ang muscle siya and to check if problems. So, start with the side, sir. Sige, tayo muscle, sir. Muscle. Okay, so, 80. So, sir. Sige, sir, tayo muscle. Okay, so 14 ang mukhang kumbitin. Ito yung proceed sa test. Okay. So, hi sir, kung kanang mga buhatonan sa balay sir, asa mo kayo usually mag-isod?
Eating dressing o ganang mga ganito na to isahan.
Kanang mga hand movement mo sir, mag-isod ka. Okay. So, for the special test, so first is resistance supination. So, sir, I want you to try to lift your hands upwards sir. Sige, 1, 2, 3, go. Sige, try.
Okay.
Kanan sir, sakit. So, positive pain and resistance supination. So, last sir, from this position, try to raise your hands sir. Sige, ready? 1, 2, 3, go. Okay, so upon wrist extension, there is noted radial deviation. So, thank you very much sir. Okay, so we're done with the O part. Now for the problem list, pins and needles pain on the posterior forearm and provocated by resistance supination. And there may be swelling and inflammation at the proximal posterior forearm. There may be atrophy on the posterior forearm, limitation of motion on supination, wrist extension, finger extension, and ulnar deviation. And there may be decreased muscle strength on supinators, finger extensors, wrist extensors, and ulnar deviators. And there is decreased functional independence as to dressing, eating, and fine motor skills. So now we proceed to the plan care. And here will be your PT for today, sir. So we'll start our treatment, sir, with the TENS machine. So the TENS machine will help you decrease your pain and increase your comfort for our during exercises, sir. So before we start, sir, to test your body's hot when it's cold, sir. So tell me, sir, if it's hot, so tell me, cold, when it's hot, sir. Here, close your eyes. Then, sir, cold, okay, then, sir. Okay, good. So we'll proceed, sir. So sir, start, with the TENS machine, sir. So okay, you open your arms, then put the left foot, same posterior, then move in, sir. Okay, so set parameters, conventional TENS, 50, pulse duration, then 1 pulses per minute. So sir, we'll be doing this for 10 minutes, and we'll be doing this for 30 minutes, sir. I'm telling you, if you feel uncomfortable, and make sure you don't sit sa kanina, so let's wait therefore 30 minutes, okay? Okay, so showing the 30 minutes is done. So, record machine. Sir, checking for sir, we'll be proceeding with massage. Help you promote blood flow for your muscles so that we will be preparing for our stretching and motion strengthening exercise. So, sige sir, start po sir. Okay. We'll do this for 5 minutes in one sir. So, okay. Okay, so we'll do this for sir. Wala din sir. Okay, sir. So, this will promote blood flow. Okay. Hi sir, now we proceed to our next exercise, which is our stretching exercise. So we will stretch your muscles in order for us to prepare for the range of motion exercises and the strengthening exercises. Specifically, I will be stretching your supinator and your wrist extensor muscles. So first na action sir is I want you to straighten your so sir. So I want you to straighten your elbow and mag-bend yung wrist na so anong position. Okay, and then what I will do is I will push your wrist adong sa imong body sir. So you see sa atong supinator. So same lang sir anong position sir. Pero imong i-bend yung so saan ang i-bend yung adong dire. Then ang hatag resistance, there is resistance here. Okay, sir. Okay, like that. So same we'll be doing this for 5 reps and 2 sets with 30 seconds. Okay, sir. So proceed to our active range of motion exercises. Okay, sir. So what I want you to do is I just want you to follow my actions sir. So first sir, with this one, straighten your elbow, okay, and then you bend the elbow sir. Okay, again, like that, then you bend the elbow. Okay, sir. We do this for each exercise we do this 10 times then 2 sets. Ready? Go. 1. Okay, again, 2. So this will be performance another motion called ulnar radial deviation. So it happens stabilize gapon here. Sana, then another one here. Okay, ana, then sa 30. Ready? 1, 2, 3, go. 1, 2. Okay, 2 sets again. Clean up. 1, 2, 10. Okay. And then I'll proceed to coordination and supination. I will hold here. Then yan ang imong hang. Imong hang. Ready? 1, 2, 3. 1, 2, 3. Go. 1. Okay, sir. 2. Okay, so this will happen. 3, 4. So sir, we're done with our range of motion. Now we proceed to strengthening. So it's our progressive strengthening exercises using figure weights. So we'll be doing this for 8 reps and 2 sets. This is in order to increase muscle strength. So do this first, do supination. So ask the patient to do this position, and then instruct the patient to put the upper part of the barbell downward. So do this for 8 reps and 2 sets. 1, 2, 3. Okay. So next exercise, the patient to do wrist extension. So ask the patient to put his palm downwards while holding the weights. So ask the patient to while in this position, ask the patient to try to lift the barbell. Try to lift the weights. See for 8 reps and 2 sets. 1, 2, 3. Then lastly for ulnar deviators. So with the same position, ask the patient to move his wrist to the right. So 8 reps and 2 sets. So again, 1, 2, 3. So until 8. This will be the radial nerve glide. So we do this for 5 reps and 2 sets. And this is in order for to remove intramural adhesion and modulation of the painful symptoms. So ask the patient first to abduct the shoulder, then internally rotate with the wrist flex starting position. So with this starting position, I'll simultaneously externally rotate the shoulder and rotate the opposite side. So do this for 8 reps and for 5 reps and 3 sets. 1, 2, 3. Lastly, functional training. So times 10 reps for 3 sets to facilitate carryover functional independence. First is the use of a water bottle. So ask the patient to hold the object and perform wrist movements. And for forearm and wrist movements. So first, forearm and supination. Ask the patient to perform forearm supination for 10 reps and 2 sets. After forearm supination, pronation and supination, ask the patient to perform wrist flexion and extension with the object. So again for 10 reps and 2 sets. Then afterwards, put the elbow in a 45-degree angle, then hold the medial forearm and ask the patient to perform ulnar and radial deviation. 1 for 10 reps and 2 sets. So for ulnar deviation, and then you can slant the elbow for radial deviation. Okay. So next is to the use of a rubber band. So this is for the wrist flexors and wrist extensors, increase muscle strength and improve grip. So for 10 reps and 2 sets. So ask the patient to stretch out the rubber band. So that's all for pin.
So we move on to another type of radial nerve injury, which is Wartenberg syndrome. So what is Wartenberg syndrome? It is a compressive neuropathy of the superficial sensory radial nerve, SRN, also called chiralgia parasthetica. So sensory manifestation only and presents with no motor deficits. So in this picture, you see the radial nerve, the superficial branch of the radial nerve. The superficial sensory branch of the radial nerve arises from the bifurcation of the radial nerve in the proximal forearm. It travels deep to the brachioradialis in the forearm emerges from between brachioradialis and ECRL, proximal to the radial thyroid, and bifurcates proximal to the wrist. So when this is compressed by scissoring action of brachioradialis and ECR tendons during forearm pronations. So history and associated conditions. So the person may have a history of trauma, forearm fracture, handcuffs, tight wristband, wristwatches, bracelet, or plaster casts. So associated conditions. This is associated with Dicker-Vein's disease in 20 to 50% of the cases. So on prognosis, spontaneous resolution of symptoms is common. Treatment outcomes is good, and 74% success after surgical decompression.
So, ano siya ma'am, no? Akong bata na yung test ko sa ma'am, sensory assessment. I will be doing sensory assessment. This test I will do to determine if there are any impairments ng sensation. Makafeel ba ka rin? Makafeel? So, okay. So, start ko ma'am. Ingal ko ma'am nung una kay pa-feel na pain or wala. Okay? So what I want you to do is close your eyes, and I will do the same other instructions, okay? Okay, so tikas hand, okay? Okay, so next tayo, soft touch. So ako lang, same na yapon, na ka na-feel or something. Okay, yun lang ko. Ayaw ang tanamon. Okay. Okay, so next time, ako ni pressure. Kapila ka pressure, ma'am? Kapila ka pressure? Okay, kapila ka. So, okay. So, next time, I'll check for your reflexes, okay? Any reaction to this. Okay, so kanila. Ayaw kanila. Ito kanila kami. Ito kanila kami. Tikman ka nila ko. Okay, so next time, I will be doing provocative tests, ma'am. Special tests to make sure that I can confirm the diagnosis. And this test provokes or sakit-sakit na siya kaya atong panitawag ng asa dapit ang pain. Okay na, ma'am? Okay. Okay. Tingnan ko dito sakit na, ma'am. Okay. So, ano yung ginatawag na Canal sign. So, kung ipangitan is pain when I touch. Okay? Okay. So the next is I will do is move the hand to find something. Okay, there. When I close the one. Okay. 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 So for the plan of care, ma'am, I will introduce you to a assistive device or an equipment that you can use to immobilize and prevent it from moving. The hand is called the wrist splints. So in this wrist splints, it would function is it would immobilize your wrist from moving and prevent it from exacerbating the pain or sakit. So, we put it here like this, So, to prevent it from moving, So, strap lang kadiha, strap lang kadiha, strap lang kadiha. So, when you do activities or when you go outside and do your work, butang mo ni para ma-mobilize siya, hindi siya mo sakit. Okay? And I would advise you to rest this hand, ma'am. So, next is we will be doing so for the next intervention, I will introduce you to an equipment called paraffin wax bath. Okay, so in this paraffin wax bath, I would this will try to decrease the pain and hopefully makuha ang pain. So ang bottom one is you try to dip the hand like this, and dip the hand and then kuhaan mo siya. Dito mo na. Okay, dip the hand. So, brush mo siya. Brush mo ko diha. Okay, inalo ko mga if naisakit. If init ko sa kayo or sa ba. So, ayaw katog mga don't make a necessary movements that. Okay? Okay, ma'am? Okay, ha? Yeah. Okay. Okay. So, we will do this for 15 minutes. So, after 15 minutes, yan siya tantangon. Okay? Kapuhan. Yan siya. So, on this next exercise, ma'am, we will be doing nerve glide to decrease pain and assist in modulation of neural symptoms. Okay, ma'am? So what you're gonna do is put this in open and then try to put it like that. Okay? So once you do it like this, twist ka, and at the same time, erase mo yung shoulder like that, and you bend your head. Okay? So, ito na siya. Is idungan og waist. Then, so kani siya ang mahita po gud naman kay it would help the nerve to move okay, para mawa ang compression or irritation. Siya, idungan, pwede mo idungan. Pwede mo madungan. Okay, good. So, sama to ma'am. Okay, okay. So, on the next exercise, we will be doing range of motion exercises, okay? To regain your movement and without pain and increase functional use in affected hands, okay? So, we will be doing this as tolerated for you, ma'am. Okay, ma'am? Okay. So, first is, follow lang yun, okay? Tayo po doon. So, feeling mo, ma'am?
Okay lang.
Okay lang, sige. So, next, try, siya? Okay. And the next, try, okay. Okay. Then the next try. Narasakit mo?
Gamay, pero okay lang.
Ito lang. Sige. Next try. Okay. So, you can do this at home, ma'am, and pwede naman siya balik-balikan, no? Para mas train sa ang pagbalik sa functional use sa imong hand. So, in the next, activity modification. So, in this, instruct na ko nimo ma'am nga, ayaw lang butang og any type wristwear, mga relo, mga bracelet, yung sa padihang ibutang sa mga wrist. Ayaw lang kayo siya i-compress para di mo balik ang sakit, no? So, if ever, pwede, ato lang ka sa pikas kamot mag-relo, ano. Okay? So, i-rest na yung hand as much as possible. So, and gamita ang wrist splints. So I think that would be all, ma'am. Thank you.
Thank you.
Pronator Teres syndrome, affectation of the median nerve. Patients' occupation that contribute to this injury are occupations that involve a lot of forearm pronation and supination, such as cashier, cook, server, dishwasher, dentist, mechanic, concrete worker, shoveler, and clerk. Also, heavy labor, repetitive grasping, using of vibrating hand tools, scraping dishes, and packaging motions. Patients commonly complain of aching pain over the proximal volar forearm, forearm pain when elbow flexion is resisted with forearm supination, or when forearm pronation is resisted with elbow extension. Sensory disturbances, distribution of the palmar cutaneous branch of the median nerve, such as numbness and tingling over the palm and the first 3 digits. Weakness and cramping in the hand and in the forearm. So there is also decreased grip strength. Mechanism of injury is the compressive injuries, extensive, repetitive, forceful, or prolonged use of the elbow and forearm. Associated conditions are with medial epicondylitis, diabetes, and hypothyroidism. Imaging studies, the X-ray, so we look for the supracondylar process of the humerus. Other diagnostic tests are the electrodiagnostic studies, EDS, such as the nerve conduction velocity, NCV, and the electromyography. Evidence of denervation in the median, innervated muscle in the forearm, Pronator Teres, flexor carpi radialis, and flexor digitorum superficialis. So for the muscular assessment, we do palpation, so we assess for tenderness to palpation over the Pronator Teres muscle. So there is tenderness here in the proximal volar forearm. Manual muscle testing for forearm pronation and supination is done with the therapist instructing the patient first to have their palms facing the ceiling, and then instructing them to face it towards the floor. So that is for forearm pronation, while we add resistance. So, Miss, please face your palm to the floor, towards the floor, while I add resistance. So that is forearm pronation. Forearm supination is from the palm facing the floor to face it towards the ceiling, while we add resistance. So please face your palm towards the ceiling. So that is supination. Abduction is done by instructing the patient to place their thumb up and then pushing it down for resistance. So don't let me push your thumb down. That's for thumb abduction. For PIP flexion of the index and middle fingers, we ask the patient to flex their finger or to bend their index finger towards the palm, and we add resistance to it. So we say, bend your index finger towards your palm and don't let me push it down. And then also for the middle finger. Logical assessment, we utilize the superficial sensations by the pain, temp, and light touch. So this is an example for pain. So assessing for the first 3 digits and the palm for sensation. So we assess here for pain using the sharp end of the reflex hammer. For a special test, the Canal sign may be positive over the nerve proximally but not at the carpal tunnel. So we produce a tingling or paresthesia in the median nerve distribution by tapping. So we tap here. This comprises of pain and tenderness along the proximal volar forearm, limitation of motion during thumb abduction, PIP flexion, forearm pronation, and supination. Altered sensations of palmar cutaneous branch of the median nerve, so the palm and the first 3 digits, secondary to compression of the median nerve. Difficulties in ADLs, particularly in gripping with the fingers and thumb. So the plan of care is conservative treatment comprising of rest, activity modification, splinting, physical and occupational therapy for 6 weeks. Non-PT management includes NSAIDs to help reduce inflammation, analgesics to control pain, and surgery. Infrared radiation therapy using the near IR luminous light on the proximal volar forearm at 350 nm wavelength, frequency of 4x10 Hz for 10 minutes to relieve pain, promote muscle relaxation. So patient is positioned in sitting with forearm supported with a pillow or foam, elbow is flexed, wrist in neutral position and palm open. PNF hold relax technique, utilizing the autogenic inhibition for 5 repetitions with 10 seconds hold for 2 sets to relax pronator muscles that are tight. Also improve range of motion and muscle tone. Patient is positioned in sitting, facing a table with forearm supported with a pillow or foam, elbow is flexed, wrist in neutral position, palm is open. Therapist is directly across the patient. So for forearm pronation and supination, with a palm facing towards the ceiling, we passively move it towards pronation. Then halfway there, we add resistance. So we tell the patient to maintain the position while I add resistance, holding for 10 seconds, and then after that is moving it into a new range to pronation. After that, we relax the muscle again. For forearm supination, it's the same but with the palm facing towards the floor. We passively move the palm towards the ceiling. So halfway there, we add resistance. So keep that position. Don't let me push it down. And then after that, we move it to a new range and then relax. So that is forearm supination. For thumb abduction, we passively move the thumb upward. So halfway there, we tell the patient to hold that position. So don't let me push your thumb down. After that, we move it to a new range and then relax. For PIP flexion, so for the index finger flexion, we passively move the patient's finger towards flexion, and then we tell the patient to resist the motion, to hold the position. After, we move it to a new range, and then relax. Is gentle stretching to sustain and lengthen previously shortened pronator muscles, done for 5 repetitions with 10 seconds hold for 2 sets each. So, with forearm pronation, the elbow is placed on the table, and the therapist passively stretches it towards pronation with 10 seconds hold, 1, 2, 2, 10, and then supination, 1, 2, 10. Then for thumb abduction, it's done by passively stretching it towards abduction. And then PIP flexion is done like this, also with the middle finger. PREs with 1 to 2 pound weighted dumbbells performing forearm pronation and supination. To further strengthen the movement and pronator muscles, patient is in sitting with the wrist hanging off the edge of the table support to apply gravity for resistance. The patient is asked to grip the dumbbell and then turn it like a doorknob. Done for 10 repetitions with 2 sets. Static splinting using custom elbow splint with slight elbow flexion, forearm supination with wrist in neutral position, and slight thumb abduction. This is to relieve compression and immobilize the forearm to avoid movements that will elicit pain. Worn before injury, before and after treatment, and during sleeping. Functional exercises such as gripping exercises done for 5 repetitions and 2 sets to increase muscle and hand grip strength and to improve functional abilities. So this is a toy that we can use for gripping techniques. So we just ask the patient to pull down the string using the middle finger and the index finger. Hand exercises using a rubber band, done for 5 repetitions and 2 sets. This is to improve muscle strength and hand grip strength and overall functional abilities. So for thumb abduction, we tie the rubber band around the index and the thumb, and we ask them to separate the thumb from the index. This is for thumb abduction. For finger abduction and extension, we place it over the fingers and we ask them to separate their fingers, so to stretch the band. Patient education comprises of exacerbating factors and movements, exhaustion and rest, modify activities to rest the affected structures, and patient is advised to use the custom elbow splint for rest and avoid aggravating movements.
So the median nerve injury or the anterior interosseous nerve syndrome, it's a pure motor neuropathy, which is an isolated palsy of the FPL, FDP, and the pronator quadratus. So the examination and results include history taking. So for the patient's occupation, occupations involving repetitive finger gripping or squeezing and repetitive forearm motions, especially pronation and supination. So for the chief complaint, these are poorly localized aching pain in the anterior forearm and the cubital fossa, difficulty bringing the distal phalanx of the thumb and the index finger together, difficulty forming a fist, and also difficulty in buttoning a shirt. So for the HPI, these are traumatic and spontaneous injuries. So forearm fractures, penetrating injuries, taboos, cast fixation, and viral neuritis. So for spontaneous, these are brachial plexus neuritis, compartment syndrome, and compression neuropathy. So the past medical history or the associated conditions are rheumatoid arthritis, gouty arthritis, and parsonage-Turner syndromes. And for the imaging, these are MRI and ultrasound imaging. For palpation, the therapist will be palpating the patient's anterior forearm, and then the patient will feel tenderness and pain upon palpation, so the tenderness reading will be used here. Next, we proceed to the range of motion assessment. First, we will assess for forearm pronation. So the patient will be in sitting, and then the patient's hand and forearm will be in neutral position, and then you'll be instructed to face your palms downwards, like that. So, okay, so ma'am, I want you to face your palm downwards. Okay, and now take the range of motion. So next for range of motion is wrist flexion. So the patient's hand will be dangling at the edge of the table and will be instructed to bend the wrist towards the floor. So let's start with the ma'am, okay? So what I want you to do again is to bend your wrist towards the floor. Ready? 1, 2, 3, okay. So next we assess for thumb flexion. So the patient will be instructed to bend their thumb across their palm. So with this, start na ta. Okay, bend your thumb across your palm, ma'am, please. Okay. So that is for thumb flexion. Next we move on to finger flexion. So the patient will be asked to bend their fingers towards their thumb gapon, so like that. So with that one. So ma'am, I want you to bend your fingers towards your palm. Okay, and then measure for the diameter. And so that will be. It was noted that the patient had limitation of motion as to forearm pronation, wrist flexion, and first to fourth digits of finger flexion. Next, we move on to manual muscle testing as to forearm pronators. So with this, the patient is asked to turn their palms towards the floor, and you as a therapist will add resistance. So, okay, ma'am, I want you to turn your palm towards the floor and add resistance to the therapist. Okay. Next, we move on to wrist flexors. So the patient is with their palm in supine, the therapist will add resistance as the patient bends their wrist towards the ceiling. So, okay, ma'am, I want you to bend your wrist towards the ceiling, and I'll add resistance. Okay, so wrist flexion and then add resistance. Proceed to thumb flexion. So the patient will be asked to bend their thumb towards their palm, and the therapist will add resistance. Okay, ma'am, so I want you to bend your thumb across your palm and add to resistance. Okay. So now we move on to the second to fourth finger flexion. So the patient will be asked to flex their thumb towards their palm and add resistance to the therapist. Okay, so I want you to bend, okay, your fingers, okay, bend then add resistance. Okay, so it was indicated that the patient had muscle weakness as to their forearm pronators, wrist flexors, and their first to fourth digits nga flexion. So next, we move on to muscle bulk test, wherein this is to identify if na by atrophy si patient. So first, we will identify if na si atrophy sa iyahang medial proximal forearm. Okay, so using a tape measure and locating kung asa ang pinakadako nga bulk sa iyang muscle. Okay, so this is to assess if na by atrophy. So you will do that on both sides. MBT for thinner muscles, the tape measure will be placed in ulnar styloid to radial styloid process. Then your fifth metacarpal to your second metacarpal joint back to your ulnar styloid process. Okay, so like that. So with this, you will be doing this to the other extremity. And then the MBT, it was indicated that a patient had atrophy on the proximal forearm and the medial side and their thenar muscles. Next is sensory assessment. So this will be done in order to rule in or rule out any other conditions and also to check if na by impaired sensation to the patient. So with this, the patient will be instructed to close their eyes and open their eyes and do it for 10 times on their arm and also to the other side. So first, you'll be testing for hot and cold. So the patient will say, if you feel hot or cold, okay, so start that. Hot, cold, hot, cold, hot, hot. So assuming that has been done 10 times, eyes open, eyes closed into the other arm. Next is we move on to dull and sharp. So this is the sharp end of the reflex hammer and the dull end. So start that. Dull, sharp, dull, sharp, sharp, dull. So assuming that has been done 10 times and also to the other arm, eyes open, eyes closed. So it was noted that patient has unimpaired sensation since AIN is a pure motor neuropathy. Fine motor skills assessment. This is to identify if na by any impairment patient fine motor skills, especially for grasp and pinch. So the patient will be tasked to grab the coin using a pinch grasp. So the patient will have difficulty in getting the coin. Okay, next is the patient will be given a pen using the pinch grasp yapon, and also, so the patient will have difficulty in grasping the pen. Lastly, patient will be ordered to grasp this tape. The patient will have a difficulty in grasping. Okay, so it was noted that the patient has impaired fine motor skills since patient could not approximate their thumb and their index finger, and also they are unable to make a pinch grasp and also to maintain their grasp. First, for the special test, we have the pinch grip test, wherein the patient will be asked to approximate their index tip of the index finger and their thumb together. So it would be like that. However, the patient with AIN would have a pinch grip like that, or sometimes they may not be able to flex their index finger and thumb all together. Next, we have the sign of benediction, wherein the patient is asked to make a fist, and then the first and second fingers will have difficulty flexing while the other digits flex. So the patient will have something like this. However, the third and fourth digits may be able to flex, but they are weak. So for the upper limb tension test, patient feels pain upon shoulder abduction with full supination and extension of elbow, wrist, and fingers. So this indicates anterior interosseous nerve syndrome when patient feels pain. The problem is these are aching pain on the anterior forearm, LOM as to forearm pronation, wrist flexion, and finger flexion on the first to fourth digits, muscle weakness on the forearm pronators, wrist flexors, finger flexors on the first to fourth digits, atrophy on the medial side of the proximal forearm and on the thenar muscles, impaired fine motor skills, and lastly, decreased functional performance on ADLs, especially as the pinching with index finger and thumb, and also upper extremity dressing as to buttoning the shirt. So first, for the plan of care is conventional tense on the anterior forearm with a frequency of 80 Hz, pulse duration of 30 ms, and intensity of 3 MA for 15 minutes to relieve pain. So okay, buta ang parameters here, and then it will relieve pain. And then after 15 minutes, the pain it will be taken out. So next is we'll be doing some median nerve flights for 5 reps of 3 sets. This is to promote neural mobilization of the median nerve and to also decrease their pain. So what you're going to do is to instruct patient to put their arms straight out to the side and about parallel to the ground. So turn their palm up and keep their fingers straight out. So and also you will instruct them to side bend their head and rotate their head downwards like they're looking at the ground. So still with the palm up and fingers straight. So instruct them to move their palm up and down. So next we will be doing some stretching exercises using the hold relax technique for 5 reps, 2 sets, and 10 seconds hold. This is to increase range of motion and to prevent contractures. So first is forearm pronation. So with the forearm in spine, we will instruct the patient to let their palms face toward the floor. And the therapist will be giving resistance, so you instruct the patient to match the resistance given to them. So I want you to face your palms towards the floor and match my resistance. Okay, and hold this for 10 seconds. Okay, and then after relax. Then do that again for 5 reps and 2 sets. And so next we move on to wrist flexion. So for wrist flexion, I want same gap instructions, but I want you to bend your wrist towards the ceiling and still match the resistance. Okay, ready? Start. Ready? 1, 2, 3, go. Face towards the ceiling. Hold for 10 seconds, and after 10 seconds, relax. That's for wrist flexion. For thumb flexion, so I want you to instruct the patient. I want you to move your thumb across your palm and still match the resistance given. So with that, okay, so hold this for 10 seconds, matching the resistance, and then relax. So repeat that 1 to 6 sets and reps. So for finger flexions is you instruct the patient to bend their fingers towards their palm and still match the resistance given to the patient. So bend the claw fingers, match the resistance, please. Hold for 10 seconds. After 10 seconds, is relax. Next is progressive resisted exercises using 1 pound dumbbell performing forearm pronation and wrist flexion. So this is done for 5 reps in 2 sets in order to increase muscle strength and to maintain muscle integrity. So with the forearm like this and with the dumbbell held, kaya mag-forearm pronation siya while holding the dumbbell. And then for wrist flexion, the patient can place their forearm on a stable table, then mag-bend nila lang wrist forward or upwards. This is grip exercises using a stress ball. So assuming that this is a stress ball, this will be done for 5 reps and 3 sets and 3 seconds hold in order to improve wrist and finger muscle strength and also to improve functional performance in ADL. So the patient will do this for 5 reps and then every rep hold sila 3 seconds. After 3 seconds, release and balik na sad na. Next is fine motor skills training. In the sitting position, this will be done for 15 minutes to improve pinch grip and to increase functional performance in fine motor skills and activities. So first is flipping over and stacking buttons using the thumb and index finger. Next activity is buttoning the shirt up and down. Next activity is grasping pen and handwriting such as their name, age, address. For other treatments, splinting of the elbow near 90 degrees of flexion or position of most comfort for the patient, and splinting of the thumb IP joint to allow the patient to continue performing ADLs. For patient education, patient is educated on to avoid motions that would exacerbate symptoms, on activity pacing and to rest when needed, and also on proper body mechanics.
The next condition is the median nerve injury, and its injury is what we call the carpal tunnel syndrome or CTS. For the examination and results, first we have history taking, patient's occupation that are at risk or can possibly have carpal tunnel syndrome. We have musician, those that are stringed and percussion instruments, keyboard, clarinet, and violin. Manual work that involves high repetition, like computer-related jobs, construction jobs, restaurant and food service jobs, manufacturing and industrial jobs, and healthcare jobs. Also, strenuous work activity and occupational history of repetitive hand movements, involvement in a workers' compensation case, and use of vibrating tools. We also have keyboard or typewriters, and athletes like cycling, tennis, and throwing.
For the chief complaint, the patient may complain of pain or aching sensation over the ventral aspect of the wrist. The pain can radiate distally to the palm and fingers, or more commonly extend proximally along the ventral forearm. Patient may complain of pins and needle sensation, hand numbness at night, and that the hands may fall asleep, or that things slip from their fingers without noticing, weakness or clumsiness because of the loss of power in the hand, especially in precision grips involving the thumb.
Next is for the
History of present illness.
or the HPI and the mechanism of injury or the MOI. We have repetitive trauma or strain, especially with wrist flexion, dislocation with injury, and a wrist fracture.
Carpal tunnel syndrome may be associated with diabetes mellitus, long-term wheelchair use, rheumatoid arthritis, gout, mixed edema, scleroderma, amyloidosis, pregnancy, hypothyroidism, obesity, giant cell arteritis, Jardian syndrome, and systemic lupus erythematosus.
So next time we will be doing a range of motion tests, which is to determine if there are any limitations in your joints with the different joint motions, especially with your wrist. Okay?
Ma'am, I want you to bend your wrist towards you with your fingers relaxed. Okay. Now I want you to bend your wrist back away from you. Okay, very good. I want you to bend your finger toward the palm of your hand like this. Okay, very good. Now, ma'am, I want you to bring your thumb up like this. Okay, now I want you to bring your pointer finger towards the thumb like this. Then middle finger, and then ring finger, and then pinky. Okay, very good. Let the patient hold different objects: the spherical object, a hook object, cylindrical object, a toothpick, piece of paper, key,
Yes, ma'am. Up. Bend. Yes, ma'am. Up. Bend. Up. Straight. Up. Straight. Bend. Up. Muna siya down. Up. Down. 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 Yes, ma'am. Up. 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 Down. Up. Down. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am.
Okay, ma'am, please tell me if you feel 1 or 2, okay?
2, 2, 2, 2, 2, 2, 1,
Okay?
2, 1.
Okay, so let's measure the distance. So it's about 3 centimeters, which means that it is
Yes, ma'am. Yes, ma'am.
to check for the Canal sign, lightly tap over the median nerve distribution.
Ouch! Ouch! Ouch!
Ano sa'yo mo na-feel?
Nagkurente.
The wrist thickness is 7 and the wrist width is 9. So the ratio is 0.77, which is greater than 0.7, which means that the test is positive. Ma'am, do you experience any wrist pain at night?
Yes.
What do you do to relieve the pain?
For the functional outcome measures, we have first the Boston Carpal Tunnel Questionnaire. This is to examine symptom severity and overall functional status of patients with carpal tunnel syndrome. It has 11 questions. So here it is. Next is
Another functional outcome measure is the disability of the arm, shoulder, and hand, or the DASH. Questionnaire is a 30-item questionnaire that looks at the disability of a patient to perform upper extremity activities. This questionnaire is a self-report questionnaire that patients can rate difficulty and interference with daily life on a 5-point Likert scale.
the Brigham and Bowman's Carpal Tunnel Questionnaire to measure symptom severity and functional status in patients with carpal tunnel syndrome.
Another functional outcome measure is the patient-rated wrist evaluation, or the PRWE, which is a 15-item questionnaire designed to measure wrist pain and disability and activities of daily living.
And lastly, the carpal tunnel median nerve function disability form. This is to measure severity of symptoms and functional disability of the median nerve. Here it is. For the problem list, next is the
Problem list: the patient has pain over the ventral aspect of the wrist that can radiate distally to the palm and fingers, or more commonly extend proximally along the ventral forearm, pins and needle sensation and numbness, LOM on wrist flexion and extension.
decreased muscle strength on wrist flexors, extensors, thumb abductors, and opposition musculature. We have also atrophy on the thenar muscles, impaired sensation, and impaired ADLs and IADLs involving the upper X, especially the wrist, hand, and fingers.
Set the ultrasound to 1 MHz, 1 watt per cm squared, pulse mode 1:4 for 15 minutes over the volar aspect of the wrist for pain relief. Place the immersed medication hydrocortisone on the electrode pad and place the electrodes on the volar aspect of the wrist. Do it again. This time, do it to the dorsal aspect of the wrist for 10 minutes for pain relief. With the wrist in neutral position, bend the fingers and thumb to form a fist. With the wrist in neutral position, extend fingers and thumb straight up, keeping thumb in line with fingers. With fingers extended, extend the wrist back. With fingers and wrist extended back, move the thumb forward away from the fingers. Maintain the previous position and supinate the forearm by rotating your palm toward your face. Maintain the previous position and gently stretch the thumb back with the other hand. Straighten your arm and bend your wrist back. Use your opposite hand to apply gentle pressure across the palm and pull it toward you. Straighten your arm with palm facing down and bend your wrist so that the fingers point down. Gently pull your hand toward your body. Place your hand palm down on a table or flat surface. Gently straighten your fingers as flat as you can against the surface. Place your palms together. Have your elbows touch each other. With palms pressed together, slowly spread your elbows apart. Other treatment for carpal tunnel syndrome is splinting. The physician may prescribe volar wrist splint to limit wrist motion and place the wrist in neutral position. This might help the patient at night to reduce the feeling of discomfort. Ma'am, I want you to avoid repetitive or awkward activities that precipitate paresthesias on the hand and avoid prolonged bent position of the wrist, okay? So I also want you to maintain proper body mechanics all the time, avoid slouching and forward-headed posture, and take frequent breaks when doing repeated activities if possible, ma'am, and use alternate hands when completing tasks, okay?
Next is the homework modifications. So we have to use an ergonomically correct workstation setup and posture. We have to avoid slouching and use mouse pads with wrist support and properly align keyboard to avoid working in a bent wrist position.
The patient may use special gloves or wraps around tool handles to reduce vibration if it is a factor at the workplace. The patient may also use adaptive scissors and shears. The patient may also wear gloves to keep the wrist and hands warm, and the patient should reduce or stop activities that increase the symptoms until they are less frequent or intense.
Good afternoon, sir. My name is Elsie Emery. I'm Casanova, and I'll be your physical therapist for today. So before we start, sir, may I know your name first?
Rafael Casanova,
Okay, so Sir Rafael, how old are you?
27.
And where do you live, sir?
Cantonman, Mandawi City.
Okay. And how about your occupation, sir?
I'm a computer operator.
Okay, so what brings you here today, sir? Do you have any complaints or anything?
I've been experiencing pain, weakness, and numbness in my hand, especially sa akong pinky and ring finger. And we use it to grasp an object.
Okay, so I've noticed, sir, na yung hand ay nag-form of claw hand. So that's probably because of the weakness in your hand. So what were the significant patterns, sir, that probably caused the condition?
I've been working as a computer operator for many years now, and then always run ko sa akong workstation, and then kami run ko mag-work overtime, which causes my elbow to feel some pressure.
Okay, and were there any tests done, sir, by your doctor to confirm the diagnosis?
MRI and EMG.
Okay, so may I ask, sir, if you have any medical history in the past few years?
I have an arthritis.
Okay, sir.
So the second point of examination is to look for the Wartenberg sign. So the patient presents with positive Wartenberg sign, so there is a slight abduction of the little finger from the wrist. So the next part, sir, is your range of motion exercise. So I'll be using this goniometer to test the joint integrity. Okay, so let's start with your wrist flexion. First, so I want to bend your wrist, support your fingers down as far as you can, sir. Okay, so wait, sir. Wait, don't relax. So I'll just place this. Okay, at the count of 3, sir, I want you to bend down. 1, 2, 3. That's it. So the patient presents 45 degrees of wrist flexion. And then this time, sir, we'll be doing wrist extension. So we'll be doing the opposite. I want you to bring your fingers towards the same size. And then if you feel weak, things are just stop. Okay? Yes, sir. For a while, sir. Okay. 1, 2, 3, up. Okay, sir. Right, sir. Okay, so the patient's wrist extension is 110 degrees. Patient motion of your finger flexion. Okay, sir, so I want you to put your hands like this. And then I'll be using a small goniometer. And what I want you to do, I want you to do like this. Move your hands this way. Okay, so first, this finger first. Okay? Okay, so relax now, sir. Okay? At the count of 3, 1, 2, 3. Bend. Bend as far as you can. Bend. On and up. Okay, so 90 degrees. The next finger. Okay. Number 1, 2, 3. Okay, so 3 degrees. Next is your finger. Okay. Right here. Okay, go. Okay, so stick. And that's your feet. So that's your feet. 1, 2, 3, then. Okay, so you just give and then repeat 5 degrees. So next, right here. This right here. This one. Approximately. So what is this? And now take the head down. Okay. 1, 2, 3. I guess repeat. 1, 2, 3. Bend down. This part. Bend. Okay, so this 90 degrees. That's really the other fingers. Then that's it. So here's right here. So right here we start like this. Here it is. And then this right here. Straight from this. 1, 2, 3. So we're going to form a box. Okay. So see. And yeah. No. Okay. Right here. Here. Okay. So 1, 2, 3. Move. And close. Okay. 1, 2, 3. Start one. Okay. So changing 2. Okay. 1, 2, 3. Go. Okay. Next. 1, 2, 3. Okay. So let's do this. 30 degrees of your left. So I find patient's finger flexion on the under the So the first is your finger flexion. So I'm not sure this right fingers on here. This so your finger flexion. Okay. So the patient is going to twist of the fingers a little. So after your fingers, we'll be focusing on the range of motion of your thumb. Okay. So what I want you to do is put your thumb towards the center corner. Okay. And then if you feel pain, just stop. Okay. Relax your feet. 1, 2, 3. Go. Okay. So your flexion is 130 degrees. And the next one is your thumb flexion. So the next motion is your thumb abduction. So I want you to move, put your hands this way, and then I want you to move your thumb towards this side. So like this. Okay. Okay, 1, 2, 3, go. Oh, move. Okay, so it's 55 degrees. Okay, sir. So for the next one, we'll be doing your manual muscle testing. So this is to test the different strength of your muscle. So first one is your elbow flexion. Okay, sir. So I want you to your right side first, sir. So I want you to bring this palm upward. As high as you can. Okay, so next is the muscle bulk test. So this is to identify whether or not there are any difference in muscle multiplications in our right and left hand. Okay, so ang areas niya in doing the figure of 8 is from the ulnar styloid to the radial styloid, and then to the fifth metacarpal joint, then to the second metacarpal joint, and back to the ulnar styloid. Okay, now let's start. Now to the other hand. So after doing the muscle bulk testing, the patient showed a significant difference in muscle bulks in left and right. So there is a muscle atrophy in intrinsic hand muscle, specifically in first dorsal and dorsal side. Now
now what we're going to do is I'll be assessing for your sensory. So this is for me to know whether or not there are any abnormal sensations at specific areas of your hand. So will that be okay, sir?
Yes.
Okay, so now first I'll be introducing you two different sensations. So first is we assessing for pain sensation. So I'll be introducing you two sensations. So this is the sharp, you feel that?
Yes.
And this is the dull. You feel that, sir?
Yes.
Okay, so now I want you to close your eyes and tell me whether it's sharp or dull, okay?
Yes.
Start.
Sharp. Dull. Sharp. Dull. Sharp. Dull.
Okay, sir, open your eyes. So I'll be assessing now your other hand. Okay, now open your eyes first, your hand. You feel that, sir?
Yes, first line.
Okay, so now I want you to close your eyes and again tell me whether you feel any sharp or dull, okay?
Yes. Dull. 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 Sharp. Sharp.
Open your eyes, sir. Now we'll be assessing for hot and cold sensations. So this is the hot and this is the cold. You feel that, sir?
Yes.
Okay, so now close your eyes and tell me whether it's hot or cold.
Hot. Cold. Hot. Cold. Hot. Hot.
Okay, now open your eyes and then here put the other hand, sir. So this is the hot and this is the cold. Okay, so now close your eyes again. 1, 2, 3.
Cold. 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 Hot.
Okay, open your eyes, sir. Now, sir, I have here 2 paper clips to test for your 2-point discrimination. So mag-anak ko paper clip here, sir, and I want you to say yes if you feel it and tell me whether you feel 2 or 1. Okay? So example, sir, ani, so if you feel the sensation, you say yes, and ilan ka, how many sensations you feel? So, ilan na, sir? 2. Okay, so ilan ka, say yes, 2, if you feel 2 sensations, or yes, 1 if you feel 1. Okay? Let's start. Close your eyes.
Yes, 2. Yes, 2. Yes, 2. Yes, 2. Yes, 1.
Okay. Open your eyes. Other hand sa sir ka. Same thing, hapon. Anak ko, and tell me whether you feel any sensation, and tell me how many sensations. Okay? Now close your eyes. Let's start. 1, 2, 3, go.
Yes, 1. Yes, 1. Yes, 1. Yes, 1.
Open your eyes, sir. Very good. After assessing patient sensory, the patient showed increased or impaired sensation as superficial sensation and the 2-point discrimination. Now, sir, we'll be assessing for your 5 motor skills. So, are you ready, sir?
Yes.
Okay, so first, I want you to try and grasp this one. Okay. So now, I want you to grasp the ball like in a circle grasp. Again. Try. Okay. So now, kaya let's try cylindrical grasp, sir. Anak. Can you do it? Wala trying, sir. Next, I want you to try and carry this case or hook. Can you do it, sir? Now, I want you to touch your fingertips, sir, and alternate. Next, sir, I want you to try like kanang more pag pinch, like lateral pinch sa tingin. Okay. Lastly, sir, I want you to try and touch your pads and fingers, sir. So after assessing patient's fine motor skills, kaya the patient showed impaired fine motor skills secondary to his muscle weakness in hand.
Okay, so for the next test, we'll be doing your coordination exercise to test your muscle coordination. So first one is your finger movement. So I want you to bring your finger. Like here. Okay, here's lahat. Next finger to me. So one finger. So next one, finger. So finger. So finger right here. Go. Here we go. So next one is here. So I'll have to do 0 here. Okay. That's it for the coordination. So that's so for the special test, we'll be doing your diagnosis. So I want you to stand up, please. Stand up. And then, hariman ko yung combination sa right side. So I want you to bring your arms like this. Like this. So I'll be tapping this area for 60 seconds. Okay? Now, baby, for 30 seconds. So if you feel any pain in your pinky and your forefinger, okay, that's it.
So now, sir, we'll be doing some special tests. So first is the elbow flexion test. So what I want you to do is to just basically bend your elbow like this, and then straighten your wrist para yung palm mag-face sa ceiling. Can you do it, sir? So I want you to hold this for 1 minute, okay? Tell me, sir, if there's any pain in home of sir, ha? Second? Okay, so a positive sign for cubital tunnel syndrome is when the patient can't hold the elbow flexion test because of pain. Next test that we'll be doing is the Pronator Teres. I want you to grab this paper with the use of your thumb and can you move your hand here. So, okay, so don't let me pull the paper. That's right. Also, sir, in grabbing the paper, don't bend your thumb, okay? So 1, 2, 3, go. Again, 1, 2, 3, go. Okay, so a positive sign for cubital tunnel syndrome is when the patient can hold the paper or if the patient bends his thumb para to hold the paper. Okay, so based on the assessment that we had sa patient guide, where the problem is the patient has elbow pain, paresthesias and numbness sa iyang fifth and ulnar aspect of the four fingers, limited of motions in elbow, wrist, and hand, weakness sa iyang adductor pollicis muscle, atrophy of the first dorsal interossei, weakness of grip strength, impaired fine motor skills, and lastly impaired ADL involving the upper extremity function of the patient.
So the plan of care for cubital tunnel syndrome for non-PT management. So for chronic cases, we require surgical management consisting of decompression, transposition of the ulnar nerve, which is reserved for severe cases manifesting persistent pain and neurological compromise. Patient can also take anti-inflammatory medications to counter for the severe pain and inflammation due to the ulnar nerve injury.
So now for the plan of care, first, we have to immobilize the impaired hand of or arm of the patient. So assuming na naay long arm splints, the elbow of the patient must be in 45 degrees flexion. So this is 45 degrees flexion. The forearm must be in neutral position and dapat you have fingers and thumb going free from the splint. So this is done for 4 weeks to rest and hasten the healing process of the injured patient. Okay, so next is the conventional test. For the parameters, 50 Hz, 50 microsecond for 20 minutes. So the electrodes are placed sa lower aspects of our patient, specifically the superior part sa elbow, so middle part, and superior to his wrist, so middle part. So this is to decrease the pain of the patient and also to increase the tissue extensibility in preparation for the exercises later on. So sir, before we start, you might feel lang, please don't do any unnecessary movements, don't move or touch the electrodes, and as we start, I want to tell you the set of pain in mga feel kay current okay? Start na sir. So start na sir. So for the intensity, can we increase ang intensity until the patient doesn't feel any pain na lang instead, kaya yung feel is ang current. Nakapin sir. So assuming that the 30 minutes is done, so ako yung musika. Okay, so next, while I was doing the sensory assessment a while ago, I have noticed that you have impaired sensation sa kanyang hand compared to that hand. So what we're going to do today is we're going to do some sensory rehabilitation program to increase your sensation and also to have better performance when you do your exercises later on. So we'll be doing this exercise or sensory rehabilitation program specifically sa mga media aspect of the lower of your hand. So here, since naaman here mostly ang impaired sensation mo. So basically what we're going to do is I'll be introducing you some different stimulus. So for the pain, I'll be using this sharp tip, and then for the hot pulse, two tests, one for hot and one for cold, and then for the light touch, I'll be using this tongue brush, and then for the pressure, I'll be using lightning. Okay, so I'll be doing this for 10 minutes each stimulus. So easier. That's good. So first, okay, give it a So now, okay, what's yung ating left hand, sir, specifically sa nila aspect of your head. So I'll do this for 10 minutes to improve sensation of pain. Okay, sir? So showing 10 minutes done, and then for the hot and cold, so this is the hot, this is the cold, okay, so now, okay, mag-cold sa your hand, so this is the cold, so I'll do this for 10 minutes, and then your sensation of pain. Showing 10 minutes done, so hot sensation. Showing 10 minutes done. Now for the light touch, I'll be using this tongue brush. We do that. So now I'll be testing this side. So I'll be doing this for 10 minutes again. You're improve the sensation sa light touch. See for the pressure? You feel that, sir? Now let's do this here. So we'll be doing this for 10 minutes, improve the sensation sa pressure. Actually, 10 minutes is done. Next, we'll be doing some gentle stretching, specifically sa elbow flexors and finger flexors. Okay, sir? So this is done for 5 reps, 3 sets, and 15 seconds hold. So these exercises can help increase the tissue mobility in the patient for active exercises on movement. So first, sir, start first elbow stretch. You do stretch, sir? Yes. So we'll do this for 5 reps, 3 sets, 15 seconds. So next, for the finger flexors. So only 91 fingers you do stretch. Yes. Okay, so this hold for 15 seconds. So this exercise is ROM and PROM, exercise using the D1 and D2 TNF pattern. So these are done for 10 reps and 2 sets for each pattern. So these exercises can help increase the range of motion in the patient. The first pattern is all you have to do is basically raise your arm up, and then one side, and then bring it upwards, and then elbows even, pose it wrist, and then go out, this side, and then your fingers. This is done for the exercise. Down, again, down. So next is the D1 extension. So what you're going to do here is dapat yung arm hard, nasa down. Yung arm is nasa ubos and then upward, and then your arm is rotated inward. Then elbows be straightened, also the wrist and your fingers. Okay? So you start for the rest of the sets. So like from shoulders, and then so next is the deep extension. So we're going to go. Kaya naman yung hard, go ahead and rotate it upwards. Yung mga elbows, and then yung mga wrist dapat naka-straighten and also your fingers. Okay, bye. So your back, yung right. Okay, so it's not the rest of the sets. Okay? Down. So next is the U extension. So we're going to carry your arm, nasa ubos. So also rotate the arms. Okay? And then yung mga elbows dapat naka-straighten and side. Also, dapat yung mga wrist and your wrist. So this is for the rest of the sets. Pacers or next exercise will be a progressive resistance exercise using this 2-pound dumbbell. So this is to increase the muscle strength in your right arm to improve your right arm function during your daily activity. So we'll be doing this set of exercise for 10 reps, 2 sets each exercise. So hold sir. So first one, give abduction. So abduction, your arm. Let it from straight. You move the upper. Okay, 1, 2, 3, go. Not your body, just your arm. Okay, 4, 5, 6, 7, 8, 9, 10, 8. Now. So next. Next one is short elbow extension. Okay, so from here. Start. From here, okay, 1, 2, 3, go. 1, 2, 3, up, 4, 7, 8, 9, 10. Doing your pronation and supination. So from this position again, from the inside, bring down, upward, down, upward, down. So next one is your wrist motion. And that's one is motion. One, you bring your wrist, bring your now, out, ready, in, out, in, out, in, out, in, out. So the next is your ulnar motion. So ulnar motion, you move and forward, 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 okay. From this position, bring the side. Point the body, straight up, up, up. Straight, straight, straight. So next one is your radial motion. So opposite foot, and then cover, do that as well. You want, you want. So next one is your 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So our next exercise is resistance exercise using a finger band. So the next exercise is still your progressive resistance exercise using this finger band. So this from this level, 1, 2, 3, for the fingers against our feet. So this will improve your fingers. So this is the better resistance. 8, 1, 2, 3, go. Okay, so our next exercise is your finger up. So from this level, this is sorry, fingers. Side jump. 1, 2, 3, go. Okay, next one, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Therapy ball exercises in sitting position for 10 minutes. This is to increase your grip strength and control for functional mobility. So I have this hand therapy ball, sir. So hold it using your right hand. So the first exercise will be your power gripping. So I want you to grip that ball hardest hand. Go. 5 seconds. 1, 2, 3, 4, 5, and then relax. And grip again. Repeat, sir. Okay, relax. Grip again. Okay, relax. So next, you change position. Move the weight. So again, you have force. Okay, so 5 seconds. Let's start from 1, 2, 3, go. Pinch. 1, 2, 3, 4, 5. Relax. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Yes. 4, 5. Yes. So next, your position. So grip up. Grip up. Hold the ball. Hold the ball. 1, 2, 3, go. 1, 2, 3, 4, 5. Relax. 1, 2, 3, 4, 5. Relax. 1, 2, 3, 4, 5. Okay, so next, your position. So hold on to your fingers. Let it stay. 1, 2, 3, go. 1, 2, 3, 4, 5. Rest. 1, 2, 3, 4, 5. Rest. 1, 2, 3, 4, 5. Okay, so next one is your finger squeeze. So we not squeeze. Okay, so squeeze 1 part time. Okay, 1, 2, 3, go. 2, 3, 4, 5, rest. 1, 2, 3, 4, 5. 1, 3, 4, 5. The last one is a meter. So same as for the morning, you do that. That is 800. But I will not. So, make sure not to reach. I'm going to 1, 2, 3, 4. No, last exercise is the fine motor skill training in sitting position for 20 minutes. This is to increase your fine motor skills to regain skills in functional activity. So the first one is I have this marble here. So what I want to do is I want you to pick your marble. Every marble is in top and everything is first. Okay, next one. Bring out marbles. This is your. Okay, go. Okay, so next is your pick the orange marble. Bring fingers. Okay, pick another. And lastly, you're not going to Uy, baka kailangan. Hey, hey. Okay, the next one is to be safer. So, I want you to stay go. We're going to close and this is open. So, making up my close up. Okay, so we have one. Okay. One, two, three, four. So what should we have? Patient table goes this is very good. And our next exercise will be running from these. This is our topic grinder. So what we do is run topic. This is answer, this and this and here we go. This is like that. Okay, answer. Okay, so one last one is your using of the so we have a table here. We have a table here. Okay, so I want you to get this marble. Using that. And then transfer to the paper. So how about let's try to put this button? Okay, so there we go. Okay, so I want you to have a mashed potato here. So I want you to eat a mashed potato. Use this answer. A mashed potato. Okay, so this is our exercise. So these are your operation. So important patient education that should be taught to the patient is the development of the symptoms and aggravating factors such as stretching or compressing the nerve when collaterally tilting the head or abducting, depressing, or externally rotating the shoulder, supinating the forearm, or extending the wrist. Patient will also be educated about the pain-provoking movements and how best to avoid them in details, which could cause aggravation of the symptoms. And lastly, patient will be educated on the wearing of elbow pads to avoid putting direct pressure on or stress on the medial elbow. That's all for your cubital tunnel syndrome.
The next PNI topic is the Guyon's Canal syndrome or ulnar nerve palsy at the wrist. So the Guyon's Canal is also called ulnar tunnel or ulnar canal. It is a fiber osseous canal located at the medial side of the hand. So it extends between the proximal border of the pisiform bone and the distally at the hook of the hamate. So the ulnar nerve and ulnar vessels pass through the Guyon canal as they pass from the distal forearm to the hand. So as the ulnar nerve exits the Guyon's canal, it is divided into deep or motor branch and sensory or superficial branch. So for the history taking, it is important to consider the patient's occupation. So this syndrome typically occurs in people who cycle long distances while leaning on the handlebars, those with prolonged repetitive occupational use of tools such as pliers or screwdrivers, as well as pneumatic jackhammers. So for the chief complaint, the patient will complain of pins and needle sensation in the ring and little finger, which may progress to a burning pain at the wrist and the hand, followed by decreased sensation. There's also pain and paresthesia along the ulnar side of the palm and of the hand and the digit. And the motor complaints may include weakness, paralysis of the intrinsic hand muscles, innervated by the ulnar nerve. So this may present as weakening of the hand grip and closing of the fourth and fifth digit. So for the history of present illness or another additional mechanism of injury, so this may occur due to trauma such as fractured hook of hamate, overuse of the wrist from heavy gripping and twisting, and improper use of crutches, which may cause excessive weight on the proximal hypothenar area. For the past medical history or associated condition, this syndrome, the rare causes of this syndrome include ganglion cyst formation, tortuous or thrombus ulnar artery aneurysm, osteoarthritis or osteochondromatosis of the basotriquetral joint, anomalous variation of the abductor digiti minimi, schwannomas, and aberrant fibrous band. So these conditions may cause compression of the ulnar nerve at the ulnar canal. So for the differential diagnosis, the two clinical findings that confirm that the ulnar canal entrapment, that it is an ulnar canal entrapment instead of ulnar entrapment at the elbow are, so first we have sparing of the dorsal ulnar cutaneous sensory distribution in the hand since this nerve innervates the volar side. There's also sparing of the function of the flexor carpi ulnaris and two medial heads of the flexor digitorum profundus. So for the problem list, we have pain and paresthesia along the ulnar side of the palm of the hand and digit, limitation of motion of thumb adduction, finger adduction, and little finger flexion. There is muscle weakness of the intrinsic hand muscles innervated by the ulnar nerve. So this muscle include hypothenar muscles, adductor pollicis, interossei, medial two lumbricals, and palmaris brevis. There's also atrophy of the interossei, the adductor pollicis, the fourth and fifth lumbricals, and the deep head of the flexor pollicis brevis. There's also altered sensation, the fourth and fifth digits, and there is difficulty in fine motor skills and ADLs as to dressing, eating, and personal hygiene, particularly in hand gripping motions. Next one we have hand body exercises.